Well, greetings everyone and welcome to the ECG Case of the Week for the week of October 2nd, 2017. This is Amal Mattu at the University of Maryland School of Medicine, and welcome back to Case of the Week. Hey, just before we get started, just want to remind everybody about my email. I put it on the first slide of every single ECG Case of the Week that we do, and I welcome people to send me emails. If you have any questions or interesting cases, please do not hesitate to just shoot me an email at that email, and I will do my best to get back to you as soon as possible. Sometimes I'm a bit delayed, but I will do my very best. Anyway, on to this week's Case of the Week. This is actually sent from Taiwan by, I'm going to do my best here, Dr. Cao Jiangsheng. And this is an emergency physician that works at the Yangming University Hospital. I think this is the first time we've gotten a case from Taiwan. Well, Dr. Jiang was taking care of a 50-year-old man who was sent into the emergency department from a clinic for chest tightness for the past 3 hours. Now, when the patient was sent over, the patient was hypotensive and had a presumed new left bundle branch block pattern. And so that was the main concern of the clinic folks that sent the patient to the emergency department. New left bundle branch block pattern with chest tightness. And that's always concerning when you've got a new left bundle. And the patient obviously has a very rapid rhythm. We'll get to the rhythm in just a second, but first of all, let's talk about these wide QRS complexes. Now, when you have a deep, wide S wave in lead V1, that certainly can be a left bundle branch block pattern, but what do you think here? Do you think this is a bundle branch block pattern? Well, this gives us an opportunity to just digress for a moment before we get back into the case and talk about what the differential diagnosis is for a wide QRS. Remember, there are a handful of things that can produce a wide QRS, and left and right bundle are only one of them. There's a handful of other things that produce wide QRS complexes also that you've always got to consider. Pacemaker beats, ventricular ectomy, for example, ventricular tachycardia. WPW can widen your QRS. Hyperkalemia does everything, right? Well, sodium channel blockers will widen your QRS. And when you don't have any of these as the causes, but you simply see a wide QRS, sometimes that's referred to as a non-specific interventricular conduction delay. One example of that is left ventricular hypertrophy. Bad LVH can sometimes widen out your QRS, and that's oftentimes referred to simply as LVH with QRS widening or LVH with non-specific interventricular conduction delay. And again, remember what the normal QRS complex is. Normal QRS complex should be less than 100 milliseconds, and truly wide is greater than 120 milliseconds. In fact, all of these are usually over 120 milliseconds. But when you've got the QRS complex in this 100 to 120 range, that's oftentimes also referred to as just some non-specific interventricular conduction delay. So this term gets used quite a bit when you've got some slight widening, but you don't have a definite cause for it. Anyway, I just wanted to take a moment to talk about the differential for wide QRS complex. Now, going back to the EKG, what is the rhythm? I think the rhythm's pretty easy, and I'm not sure if he got sent over with the diagnosis of what the rhythm here was, but this is an irregularly irregular rhythm. I think that's pretty obvious, and therefore we're in all likelihood looking at atrial fibrillation. But again, going back to that differential for wide QRS complexes that we just talked about, if they were thinking that this is irregularly irregular, in other words, atrial fibrillation with that left bundle branch block pattern, it is again important to realize that this could be something else besides just AFib with a left bundle branch block pattern. Well, one of the things that you've got to notice is that the morphologies of the QRS complexes are changing. If you look at any lead, you'll notice that some are wide. We'll go back up to V1, but some are a bit more narrow. Some are very wide. If you look at V2, there's even more changes in the morphology. So very, very changing morphologies. And the other thing that you'll notice is that in some places on this 12 lead, you're getting rates up to 250, 300, even faster beats per minute. Normally, simple AFib with the bundle branch block pattern just doesn't get that fast. So just to recap here, what we have is irregularly irregular with morphologies that are changing, and in some places, rates up to 250 or 300 beats per minute. And what I'm exactly describing is the classic example of atrial fibrillation with WPW. or Wolff-Parkinson-White syndrome. And this is a very, very important rhythm to recognize, and it's also equally important to never confuse AFib with WPW with AFib with a bundle branch block pattern, and you certainly don't want to confuse this with ventricular tachycardia either, because that can be a deadly misdiagnosis, and we'll talk about why that's the case. Anyway, in the emergency department, they decide to go ahead and just cardiovert the patient, and this is the rhythm that you've got after cardioversion. You see that the patient is back into sinus rhythm. There's still that wide-looking QRS complex, but if you look out there at the P waves, you'll notice that there's a very, very short PR interval, and there's a hint of some delta waves, some upsloping of the QRS complexes, maybe more prominent in certain leads than others. I think V5 gives you very nice delta waves, and it's very clearly a short PR. If you have any doubts, the PR is about 110 milliseconds. Normal PR should be at least 120 milliseconds. So this is sinus rhythm with WPW. Take a look. The EKG machine's not even picking up on that, and it's just calling this a non-specific interventricular conduction delay or non-specific interventricular block. It doesn't recognize that this is actually Wolff-Parkinson-White syndrome. So this is post-conversion. You're back to sinus rhythm with WPW. It's a very, very important rhythm to recognize. WPW with SVT is maybe not such a big deal. We'll talk about that again in the near future. But WPW with atrial fibrillation is a really big deal, and let's talk about that for just a moment. Now, here's an example of what's going on with normal atrial fibrillation that you and I see almost every day. Remember, when a patient has atrial fibrillation, the atrium is beating 300, 400, 500, 600 times per minute, and the impulses are going down the normal His-Purkinje pathway. And remember, before it gets to the His-Purkinje pathway, there is an AV node, and what the AV node does is it slows conduction, or it just eliminates conduction. What am I talking about? Remember, the atrium is beating anywhere from 300 to 600 times per minute. By definition, that's what atrial fibrillation is. But the ventricle, with normal rapid AFib, we've all seen this before, the ventricle is usually only beating about 150 beats per minute, plus or minus 20 or 30. We'll occasionally see AFib going up to 180, maybe 200, usually not faster than 180 or so. So AFib usually gives you a ventricular response of 150 plus or minus 20, maybe plus or minus 30. But have you ever stopped to wonder what happened to all the rest of these impulses? It's very simple. The AV node just squashed them. The AV node is very protective of the ventricle. So when the atrium is shooting down 500 or 600 impulses to the ventricle, the AV node says, no way. The AV node just squashes all the rest of them and simply sends down maybe about, again, 150 plus or minus 20 or 30 to the ventricle. So it is very protective of the ventricle. Now, if you have an accessory pathway due to pre-excitation, ventricular pre-excitation, or WPW, essentially what you've got is you have an alternative pathway for those impulses. So again, we've got the atrium beating at about 300 to 600 beats per minute, and a lot of them are coming down the normal pathway. And since they're going down the normal pathway, you get narrow QRS complexes. The AV node is also squashing a lot of them, but also a lot of impulses are heading down the accessory pathway. Notice, the accessory pathway has no AV node, and as a result, the impulses coming down this accessory pathway hit the ventricle early, that's the term ventricular pre-excitation, and they hit the ventricle in large numbers because there's no AV node stamping out the extra beats. And that's why you can get such incredibly rapid rates when you've got WPW. The other thing that you'll need to remember is that when the impulse is coming down the accessory pathway, you get wide complexes because you're producing myocyte to myocyte conduction rather than the very efficient His-Purkinje conduction. And so you've got, once again to recap, you've got 600 beats up here. A lot of them are coming down the normal pathway producing narrow QRS complexes. A lot of them are coming down the accessory pathway producing wide complexes. A lot of impulses are getting squashed at the AV node. I know I'm making a mess here, but that's okay. Hang in there. And as a result, you've got some narrow, you've got some wide complexes, and you've got some that are combination beats or fusions between the two, and the result is that you have changing morphologies. So once again, AFib with WPW, irregularly regular with morphologies that are changing, and in some places the rate can approach 250 or 300 beats per minute because of this accessory pathway up here. Let's take a look at some examples. Here is your classic AFib WPW. Irregularly regular, morphologies that are changing, and in some places 250, 300 beats per minute. And when the rate gets extremely rapid, sometimes it can be misdiagnosed as being regular. Now, looking back at this example I gave you, there's no way anybody should look at this and think that it's regular. So why in the world would anybody mistakenly call this VTach or SVT? I don't know, but it happens. Trust me, it does happen. And sometimes, again, as we found in this first case, sometimes people look at it and misdiagnose it as just plain old AFib with the bundle branch block pattern. Well, the emergency physicians here didn't miss it, but the clinic doctors just thought this was a plain old bundle branch block pattern, and we'll talk about why that can be a big problem. So let's look at a few more examples of AFib WPW. Once again, irregularly regular. Notice that the morphologies are changing, and in some places you're getting rates of 250, 300 beats per minute. Here's another example. Irregularly irregular, the morphologies are changing, and in some places approaching 250 or 300 beats per minute. Here's another example. Irregularly irregular, morphologies that are changing, in some places approaching 250 to 300 beats per minute. Here's another example. AFib, it's irregularly regular, morphologies that are changing, and in some places rates are approaching 250 to 300 beats per minute. All right, and yet another example. Irregularly irregular, morphologies that are changing, and in some places rates approaching 250 or 300 beats per minute. Irregularly irregular, morphologies that are changing, in some places approaching 250 or 300 beats per minute. I'm showing you a lot of examples of this because I think it's so important to really, really hammer this home. With accessory pathways, the morphologies have to be wide and they have to be changing. If you don't see morphologies that are wide, there's no accessory pathway. If you don't see morphologies that are changing, then it's not an accessory pathway either. Now, we're talking about AFib, by the way. The only way AFib is going to be conducted through an accessory pathway is with wide complexes that are changing morphologies. And oftentimes, again, the rates can approach 250 to 300 beats per minute in some areas. Now, let's take a look at this ECG once again. This is your classic AFib WPW. Hopefully everybody out there listening nails the diagnosis, but in the real world, what happened here is the physician didn't recognize this as atrial fibrillation with WPW. Maybe they were just looking at the area down here. I'm not exactly sure what happened, but the physician thought this might be ventricular tachycardia. Now, there's no way this can be VTach because it's irregular, but maybe he didn't notice that, and he ended up deciding to try some adenosine on this patient. Maybe because he was a young person and he figured, it's regular and wide. Maybe this is just an SVT with the bundle branch block pattern. Maybe it's VTach. Adenosine shouldn't hurt VTach. So you try some adenosine, and remember, how long does it take for adenosine to kick in? Maybe about 10 seconds. So let's take a look at 10 seconds later. Patient goes right into ventricular fibrillation. What exactly happens with adenosine, or for that matter, with all AV nodal blockers? Well, let's go back to the diagram. Remember what we said was happening with AFib WPW. You've got 600 impulses. Some are coming down the normal pathway, producing narrow QRS complexes. A lot of them are getting crushed by the AV node, and a lot of them are going down the accessory pathway, producing wide complexes. What did we just do? We just gave the patient an AV nodal blocker, and what the AV nodal blocker does is it blocks the AV node for just a short time, but nevertheless it's very potent of an AV node blocker, and it essentially shunts these 600 impulses all down the accessory pathway, which has no protective AV node, and therefore it's all too happy to conduct everything it sees. And now instead of a rate of 200, 250, 300, you now have a rate of all 600 impulses, and that produces ventricular fibrillation. And that's exactly what happened here. And the same thing would happen with administration of any AV nodal blockers: adenosine, beta blockers, calcium channel blockers, DIDGE. Case reports have shown that DIDGE will induce VFib in these patients a couple of hours later, because that's how long it takes for DIDGE to work. And also amiodarone. Amiodarone is now finally listed as a contraindicated medication Finally, in 2014, the AHA, ACC, and the HRS, Heart Rhythm Society, finally listed amiodarone as a harmful medication. After 20 years of case reports of amiodarone hurting patients, it's finally formally now been listed as a medication that you should not be giving to these patients, along with all of your other AV nodal blockers. So stay away from all AV nodal blockers. Now take a look at this for a second. This is just AFib with a right bundle. There is no accessory pathway here. Go ahead and give this patient anything you want, including calcium channel blockers or beta blockers. You can treat this patient with anything you want because there's no accessory pathway. How do I know that there's no accessory pathway here? Very simple. There is no changing morphologies. Take a look. All of these QRS complexes look pretty much the same. So I'm not worried about there being an accessory pathway. If there were an accessory pathway, the morphologies would be changing, and probably it would be faster also. Here's AFib with the left bundle branch block pattern. There's no accessory pathway. Give this patient anything that you want. How do I know there's no accessory pathway here? Very simple. The morphologies are all identical. There's no significant changing of the morphologies. Again, with an accessory pathway, in the presence of AFib, the morphologies are going to be changing significantly between the various complexes. If you see all the morphologies look identical, I'm not going to worry about an accessory pathway. I'm perfectly happy giving that patient beta blockers or calcium channel blockers. Remember, here's your AFib WPW case that we started with. Notice the morphologies are changing. In all of the leads you'll look at, you'll notice the morphologies are changing. The QRS complexes do not stay the same. That to me means this patient has an accessory pathway. All right, let's do one more case. This was sent by Dr. Jess Mason, who's a clinical instructor in the Department of Emergency Medicine at UCSF in Fresno, and she had an interesting case. She had a patient who presented with a hand injury, but just as an incidental finding on the review of systems, he mentioned that he's had a couple of syncopal episodes in the past few days, so they decided to get an EKG on this patient. And actually, during his evaluation, he had a near syncopal episode, and they managed to catch this 12 lead during his episode of near syncope. So out here, you see classic sinus rhythm with WPW. There's a short PR interval and very nice delta waves up there, but he's having intermittent runs of atrial fibrillation with WPW, and you'll notice out here, he's got changing morphologies that are wide, and also in those little sections, he's got very, very rapid rates. So this patient has atrial fibrillation, and every now and then he jumps into atrial fibrillation. An AFib with an accessory pathway can be a deadly, deadly rhythm that you and I have to be able to pick up. A short time later, the patient went back into a nice, less ugly looking rhythm, and you very clearly see out here the patient's got an accessory pathway underlying his normal conduction. All right, so quick take-home points. Remember, be on the lookout for AFib with WPW. The fact that it's irregular tells you that the patient has atrial fibrillation, but the fact that the complexes are changing in shape and width, and in some places the rates can approach 250 to 300 beats per minute, that's what tells you that there's an accessory pathway. And when you see AFib with an accessory pathway, you've got to stay away from all AV nodal blockers, including amiodarone. The only medications that are probably going to be helpful are procainamide. Procainamide's great because it preferentially suppresses the accessory pathway, so it's perfect. Flecainide, reports that flecainide probably should work. I don't have personal experience with it, and that's why I put a question mark there. As long as you don't have AV nodal blockade, flecanide's probably going to be okay. And as far as I know, flecainide does not produce AV nodal blockade the way amiodarone does. And that's why amiodarone can be dangerous, because amiodarone has beta blocking and calcium channel blocking effects. In other words, it has AV nodal blocking effects. Or the other treatment, of course, is to just cardiovert these patients. I would only use medications, procainamide in this patient, if the patient is hemodynamically stable, although most of the time these patients are not stable for very long, so I'd have a very low threshold to just go right into sedate and to shock the patient, and that will work very, very nicely. All right, folks, well, I hope this case is helpful. We'll do some WPW with normal, plain old run-of-the-mill SVTs in the near future, just to distinguish WPW with AFib. Again, WPW patients, can go into SVT or AFib. AFib is the killer. SVT, not a big deal. But AFib is a killer that you've got to be on the lookout for. And if you ever recognize it, just shock them or use procainamide, but stay away from all AV nodal blockers. All right, folks, I hope this case was helpful, and I look forward to talking to all of you next week. Bye for now.